Welcome to End of Life University. Today I'm sharing with you a conversation I had with Dr. Ira Byock, a world-renowned palliative care physician, and he and I share what keeps us up at night. So it's a bit of a rant and a little bit of whining about some things that we're concerned about right now, but I hope you enjoy listening into our conversation. Don't forget to subscribe to this channel so that you can get notifications whenever I upload a new episode. And also go to eoluniversity.com/support to find out ways you can help keep this channel and the End of Life University podcast on the air. Thank you. Here we go with the interview. Today, I'm very excited to welcome my return guest, Dr. Ira Byock, who for most of the listeners of this podcast is probably someone very familiar, but I'll read a brief little bio for Dr. Byock. He is a leading palliative care physician, author, and public advocate for improving care through the end of life. He is the founder and chief medical officer for the Institute for Human Caring of Providence St. Joseph Health, and he's the author of Dying Well, The Four Things That Matter Most, and The Best Care Possible, all three excellent books. And you can learn more about Dr. Byock at his website, irabyock.org. And of course, Dr. Ira Byock is my most frequent guest on the podcast. You just won that category by being here today. This makes you the most frequent guest I've had.
Awesome.
Yeah. So welcome back.
Quite a competition, and I'm gonna keep showing up here.
You might have to write some more books, though. I don't know.
Very much. My super ego tells me that from time to time.
Well, this conversation kind of came to mind for both of us because we had a conversation together a few weeks back where we talked about a whole category of issues that each one of us has some concern about. And so I'm calling it What Keeps Me Up at Night. And I think it's good to explore. Sometimes we have to look at the dark side and the negative side of the work that we do. And so I figured you're the best person I could imagine to have that discussion with. So I don't know, take it away if there's anything that you wanted to start with.
Yeah, so thanks for the invitation. I'm really delighted to be here. This conversation grew out of the conversation we had over dinner in Southern California recently. Just so I can set the context for our listeners and viewers, there were martinis involved, and I was relaxed, and I was giving voice to my cranky, curmudgeonly self, and I'm well in touch with that part of myself as I've thought about, just in the last day or two, knowing that we were going to have this conversation. What worries me is I don't have answers for a lot of this, and I try when I do public speaking and teaching to kind of be hopeful, and I work at being hopeful. And my day job is all about creating a brighter future, and it's substantive, and it's hopeful stuff. But there are stuff that keep me up at night that I don't have good answers for, and that are just really worrisome. So that's what we've decided to talk about, and I will just prepare the listening and viewing audience to that this is to put this in the context of everything good that's happening. But here's my anxiety closet.
And I think it's important to be able to have these discussions, because if we can't look at what the problems are, we have no hope of finding solutions to them. And we may not have solutions now, but we have to at least address the problems and be aware of them if we're going to get inspiration or find the wherewithal to address them.
Yes. And any solution that might exist begins with honesty. And I find that our field, frankly, avoids some topics and some honesty at times. So I guess as a framing of this, I think in some ways our field, and I mean hospice and palliative care, we have become the problem in many ways for people. We have, you know, lived into our darkest and commercialized potential. And I say this as somebody who was there, you know, started doing hospice palliative care work in 1978, 79. And you know, it was pretty new in this country. The Medicare benefit was passed in 1982, became a permanent benefit in 86. There were only demonstration projects and very early hospice programs when I was doing my residency in family practice. At the time, you know, we established the field, or the field kind of, you know, evolved, but with a lot of intention to make it possible for dying people to see doctors, because dying people were felt not to have needs to see doctors anymore. They, you know, in the hospital, they were quite literally often set down the hall, ostensibly for their privacy, and so, you know, to be to not have noise and interruptions, but really it put them further from the center of interest, and, you know, frankly, they got less attention. It was seen as a nursing discipline to care for dying people, and thank God for our nursing colleagues, because they were the ones who led this movement very, very much. And we were supposed to be a corrective to that. We evolved to give people the best care, to make sure that dying people and their families receive the best of symptom management, medical attention, and, you know, and psychosocial and spiritual support. Pretty simple, basically, but it was stuff that the mainstream medical disciplines were not doing. Scroll forward now 40 some years, and it turns out that in many hospice programs, you can't see a doctor. They don't do visits. Inpatient hospice is rare and very difficult to build and finance these days. So it's a home care exercise, which is fine, mostly. But we're not staffed to really support families in caregiving, and they have the biggest burden. We are particularly terrible at emergencies, and I hope we come back to that one. I'm just laying it out there. You know, let the dire beware, because some hospice programs give really awful care. Quite a few of them, I would say, in when they're stressed. For-profit hospices now outnumber nonprofit hospices by at least 2 to 1, or getting close to 3 to 1. We know that nonprofit hospices are less well staffed. If you're in a for-profit hospice, you're less well staffed. You're likely to get 10% or less nursing visits than the nonprofits. You're much less likely to see a social worker. You're very unlikely to see a doctor. The for-profits are extracting, you know, up to 20% margin from hospice care under Medicare. And that shows. And they're doing that in ways that cherry pick patients, that pick longer term patients that are less likely to need, you know, intensive care. They make it harder for the nonprofits to even stay in business because of their kind of predatory nature. It's an absolute mess.
And I can attest to that, because in my my career, I worked for a small community-based nonprofit hospice that was bought out by a for-profit hospice. And it took about 2 years before the for-profit mentality gradually took over. We continued to operate as we had as a nonprofit for a while, but we saw everything change. And eventually I was told I wasn't allowed to go visit patients, just as you described, when I had seen every patient on our service before. But I was told, we don't need you to do that. We're not paying you to do that. The nurse will tell you if the patient is qualified to be admitted or not, and you just are here to sign papers. So I saw that happen in my own experience.
It's tragic. We have the privilege of taking care of the sickest patients in the healthcare system, and they are often prevented from seeing doctors. We accept care for these people, and they're usually cared for at home. But if they have a symptomatic emergency, we tell them to call us rather than 911. But when you do that these days, you usually get, fall down in a rabbit hole of insufficient response. Mm-hmm. So if somebody is in their home and they, have internal bleeding, or, infarct their bowel, or, have any number of, emergencies, they're basically left. They need to call 911, frankly, because you're going to call a nurse. A nurse is going to take time to get back to you. A nurse may need to come out and evaluate you. He or she may need to call a doctor to call in a prescription. You may, if it's an opioid or benzo or something, you're going to need to find a pharmacist who can fill that prescription. Somebody needs to go and get it and then come to your home. Really? So, crescendo pain, dyspnea, agitated delirium, seizures. We used to be, when I was a medical director, Karen, we had contingency plans. Mm-hmm. I've published a little bit about, what goes into a real symptom emergency kit at home. What we did when I was the palliative care medical director at Dartmouth, we created a symptom severity order set, SOS kit. And in it were very small vials of injectable haloperidol, midazolam, and hydromorphone. They cost, a few dollars, really, because injectable meds tend to be cheaper. And they were only intended to be the first dose of whatever somebody would get in an ambulance or in an emergency department for, recurrent seizures, status epilepticus, severe dyspnea, agitated delirium, or crescendo pain. It worked, by the way. We knew that at least occasionally it stopped an ambulance transport, but mostly it avoided really severe symptoms, because, when a family called with real emergency, the nurse only had to get to the house. The medications were already pre-prescribed by a physician, signed, right? It was already prescribed to be given as needed per PRN, nursing discretion. The first dose was there. And then the nurse would only have to call for continuation or make plans. It bought time to then decide what needed to be done, right? When the patient was discharged or died, we simply threw them all away. Lost about $60 or $65. It worked, but of course, it's, it has gone away because of the opioid crisis and because of the lack of leadership among our professional associations and those of us an authority.
And also, I think that's a great example of patient-centric care that is thinking about what might we need in the moment to give the best care to this patient and to help with their suffering, not what is the least bothersome thing for our staff to take care of, or what do we not have policies to cover, so we're just not going to do it.
Right. You needed to get policies. You needed to, go through the P&T committees, or, we to give midazolam, we had to talk to the nursing board and the pharmacy board of the state to do that. But we did, and they signed off on it, and we did it responsibly. I've long thought that in hospice and palliative care, one of the component services we provide is crisis prevention and early crisis management plans. Again, these are the sickest patients in the healthcare system. If we're not thinking what can go bump in the night and don't have contingency plans, well, we're abandoning them when it does happen for them to figure it out. It makes no sense. And by the way, in a value-based environment, it's way too costly not to be thorough in these regards.
Yeah, and I recently talked with Dr. Jessica Zitter, whom you probably know, who's an ICU doctor, and she was saying how often they send people home from the ICU to receive hospice care at home, but the caregiver gets no training whatsoever. They're sending a very sick patient home, bringing in a hospice team, yes, but the caregiver is the person doing the burden of the care and deciding when their loved one might need more help or when they need to call someone, and they've had no training. They have no idea how to manage what they're being asked to do at home.
And this has become routine now. This is the new normal. So it's really distressing, and this keeps me up at night. I get emails from people whose mother develops agitated delirium and calls the nurse and doesn't get a response and asks to see a doctor, and there's no doctor available, and things of that nature happen. It's awful. I have an email from a hospice nurse who's really pleading with, what should she do, because she's at an agency, and I think it's a nonprofit actually, but under new management has been told that doctors no longer visit, and she has complex patients where she really feels like she needs to have a physician visit to evaluate. Unavailable.
It's interesting because I read statistics that sound good, like, well, around 50% of patients die at home now, which sounds like a good thing, until I talked to Jessica, and she was saying how she became aware of the fact that these caregivers are burning out, completely stressed, and not knowing how to take care of their loved one. And so we're sending people home, but is that a good thing? And are we making the best decisions there?
Well, I think it's a good thing to send people home, assuming that you can wrap care around them to support them. And again, I come back to, I think profit motivation drives a lot of these problems. When you have 70% of hospice programs trading on Wall Street, there is a stakeholder involved who has a legitimate stake in extracting money from this. That's impacted staffing levels. Right now, it's not uncommon for hospice nursing case managers to be carrying 14, 15 patients. These are the sickest patients in the healthcare system. They're at home. You often have to drive between their visits unless you're clustering them in a long-term care or assisted living facility. It's just, it doesn't pass the sniff test. How are they going to get good care? I would estimate, and from having, been a clinician for 40 some years, having 8 patients would be reasonable, right? 10 is pushing it. 12 starts to get untenable. 15 is ridiculous.
Yeah. Yeah. So no wonder we're burning the staff out at the same time. People
Yeah.
are leaving jobs that they have loved, that they feel called to do because they can't handle the caseload.
Yep. So there's, and we're right that, and I think we're burning them out not just because of the hours of the day, but because of moral distress, which I think is directly related to the discrepancy between your own expectations, your own quality standards, and your experience. Wow.
Yeah, so true. Well, I've heard hospice team members tell me that now the interdisciplinary team meetings that we used to have every week, I mean, theirs got moved to once every other week, and then they became shorter and shorter the time that the staff got to come together to actually plan for patients' care and talk about how things are going, but also support one another. And then she said all kinds of things started being removed. Like we no longer have start with a 5 minutes to remember our patients who died in this last month. We no longer have that. There's no longer time to sit and discuss anything. There's no longer time for the staff to share how they're feeling. It's just a cursory glance at patients' charts just to say that they had a meeting.
It's all become quite transactional, hasn't it?
Mm-hmm.
It used to be, hospice and palliative care were relational. It's a relation of people in community, experts doing the best they can to serve people who are going through the most difficult times in their lives, their individual and family lives. And now it's become sort of, transactional. What can you bill for? What's medically necessary? I was likewise on. I won't give too many details, but I was on kind of a fly on a wall in a planning call with an evolving new inpatient palliative care team, and they were talking about how one of the best hours they have all month is their interdisciplinary team meeting, because everybody can come together and huddle and discuss cases and share and introduce one another. And I was quiet, but my jaw was dropping, because in the inpatient palliative care teams I've directed and been part of, we huddled every morning.
Mm-hmm.
That's the secret sauce. That's when the magic happened. It was quick. Yeah, we opened with a poem, right? Just to center people. But then we ran the list. Who's in which patients are in the hospital? Who's seeing them, right? What are the anticipated problems? What are the goals of the day? Who are the outpatients that we've been following or now just that are in the hospital since yesterday? Who's going to see them? What's happening? That sort of stuff, it doesn't take long, but without that, it doesn't feel like team-based care, right? That was the secret sauce. So, I mean, there's so much peril, and we've developed something over the years that is so valuable. Better quality, less use of resources that people actually don't want, less time in the ICU, less time in the hospital, better, more time at home. All of that stuff is good for people's health and well-being, but it's also, frankly, costs less money. We've already developed that. Now we're kind of dumbing it down to see more patients, to do more productivity. It's immoral.
Yeah, it's so sad. I wanted to say one more thing about those team meetings. That is where synergy happens, when we bring our ideas together and our perspectives together, and then also creativity, because always for us it was in the team meetings that somebody would get the idea for how we can solve a particular problem for a patient, but it's because we came together and we at least spent some time talking about it together, and that's completely missing now, that idea of creative problem solving in the moment.
You put your finger on it. For me, the word synergy does it. The synergy for me means the whole is more than the sum of its parts. Something has happened there, right? I can't tell you how often at Dartmouth we have this still happening. Of course, the volunteers, the no one alone volunteers, not no one dies alone. Just a no one alone volunteers. We created about 30 volunteers for the palliative care program that would sit with people in the hospital. Just go by, offer them a newspaper if they could read their newspaper, get them, do an errand for them, or just sit with them and visit. Sometimes pray with them. Sometimes get them a book or a music. We had a whole little, at the time it was Walkman or, iPods. And one of the volunteers acted as a liaison and was at that morning huddle every morning. Well, sometimes the volunteers had information that kind of unlocked the case, right?
Exactly.
That made it clear what was really happening here and what mattered most. Why waste that sort of magic, that clinical magic?
Yeah, and as you were saying before, we've turned over this sacred, precious care. It's as if we've opened the doors to shareholders who we can't expect them to even understand what hospice is about or what our teamwork is about or how we give care. That's not their area of expertise. They're involved in how to make profits and how to do an IPO on Wall Street and make money
Right.
for shareholders. That's what they're good at. We've given them so much power and control over this very precious work that we do, and it's a tragedy.
And we haven't even pushed back. I mean, I don't want to start ranting against our national organizations, but we have not pushed back nearly hard enough. If you're going to have for-profit hospice care, okay, let's set quality standards, but let's have the field set quality standards so that we can really distinguish the good, the bad from the merely mediocre, right? We have to do that, and it hasn't been done. Instead, our organizations have been whining that, the Medicare stars don't work well, or, Medicare is so late and we only get surveyed every 3 years. Okay, so why aren't we doing it? What, like, I'm sorry, but, this is our responsibility first and foremost. We should be in tension with the government to help us to enforce things, but it's our responsibility to set performance standards and to at least help the public distinguish the good, the bad, and the merely mediocre.
Yes, exactly. I mean, we need to have much louder voices, and as you said, we need to push back in areas where it's important. And it feels like so far everyone is just acquiesced and said, "Okay, this is just the way it's going to be."
Right. And now, of course, with 70% of the field being owned by for-profits, it's basically impossible to change, because your board of directors, your dues-paying members on your associations are, representing a majority of them can be representing the for-profit world. They're not going to vote against. They're not going to put stringent measures in place that they're not going to be able to meet. It's the question I've been asking for decades now is, who speaks for the dying people and their family? Where's their voice? I thought we were supposed to be giving them a voice. So there's that. That's let me see where I've talked about the for-profit versus nonprofit. I should have mentioned that nowadays, not only are there for-profits being traded on Wall Street, there are now private equity firms buying up the hospices, both for-profit and nonprofit. And as our friend Dr. Joan Tino has mentioned, that's like putting introducing a predator into your environment. I mean, they exist to turn over companies and extract profit in the short term. It's wacko. So there's that. I worry about staffing levels. I mentioned that. Access to doctors, responsiveness in symptom urgencies in the home, all of that.
But the one thing I do want to say from my experience working with hospices right now is still the staff members who are drawn to work in hospice are some of the best people I know. The nurses, the aides, the volunteers, the chaplains, the social workers, everyone on the team. These are incredible people with huge hearts who really care. And so patients still may get very good care from the staff. The staff themselves might be feeling beaten up and and depleted, but they still, I believe, give the best care they're able to the patients. But
Yeah.
the stressors on them are enormous.
Thank you for that. You're absolutely right. They are our peeps. I mean, and if you're getting good care, it's because of the commitment, the professionalism, the skills of the staff, no question. I guess from somebody who's been there at the inception and has been medical director of a number of programs, of run programs, I feel like I and the leadership class has let down that staff, that we haven't resourced them, that there's not enough doctors to support them, that there's all of that. But you're absolutely right. On another shelf in my anxiety closet is the lack of cultural leadership and I think the real misconceptions that are being perpetrated by the leadership, the intellectual leadership of the field of hospice and palliative care. And it comes out in terms of the language that we use and our quote unquote brand and the like. We have now presentations. There was one just last week by our colleagues, my valued colleagues and friends, by the way, at Ariadne Labs, Eric Frome and group, talking about messaging of hospice and palliative care, the public messages that we give. And it's built on work that CAPC did with Tony Bach and Diane and others at CAPC. And it purports to show that we should not be in any way conflating or really associating palliative care with hospice, because hospice is associated with death, and hospice made the mistake of associating itself with death and comfort care. And palliative care palliative care providers should not repeat those errors, should not talk about end of life care. I could go on and on. And
wow.
These are things that now, I've attended 2 CAPC webinars on this. There are articles, these, public marketing articles marketing research articles that have been published that I have methodologic qualms with, but they're out there in the literature now. And this Ariadne webinar is like a secondary webinar of that. So this is out there. It also dovetails with, of course, is just associated with the deliberate decision to avoid the term palliative care in a number of academic and community-based programs, even though what they're doing is palliative care, but they're not going to use that term because they quickly explain people respond badly to it. They're worried about it. They associate it with hospice, and they associate it with end-of-life care and death. Now, I get much of where these folks are coming from. And I say again, many of them are my respected colleagues, and quite a few of them are genuine friends. But I respectfully and strongly disagree. I think that we play into a fear-based environment when we start avoiding calling ourselves by our proper names. And again, much like the other shelf in my anxiety closet, it's really ironic because from my perspective, so much of this field evolved from Ernest Becker's Pulitzer Prize winning book, Denial of Death. And now, we seem, so some of our leadership actually deliberately is saying we should basically be denying death, right? Use the term serious illness. Don't use the term advanced illness, right? Don't talk about dying. Get rid of those pictures in your website that have people holding hands, for heaven's sakes, right? And so my response is, how can what happened to our cultural leadership? Like, me, like, I'm an old family doc, right? I thought one of the things that we were doing as in this nascent field was reintegrating illness and caregiving and dying and grieving within a cultural, mindset of full and healthy living, this sort of frame of this too is part of full and healthy human life. Yes, it's hard. It sucks, but it's part of living fully. And I think, I and quite a few of us have tried to do that quite deliberately, to kind of, your books and I think this podcast do that. I think a number of us have tried to do that, but the field doesn't quite get that we have at least a potential role to play in cultural maturation. And instead, they're actually quite deliberately fostering this notion of denial.
Oh, it's so distressing to hear that, and amazing to me to think we're at this point. But again, I've seen that myself, because I had a person in marketing talking to me about, why do you call your podcast End of Life University? That's really off-putting. Nobody wants to hear about end of life. Why don't you do something about, you can live forever, or we don't die? Why don't you call it something like that? Because people are really comfortable with that idea. And I said, that's not what people need to learn. They don't need to learn what they're comfortable with. We have to be brave, and we have to be willing to take these risks in terms of talking about what people are afraid of. That's the only way we make progress.
And giving them a healthy alternative to the fear, right? If we act out of love, we encompass, our arms go out in an embrace. You act out of fear, you're doing this, right? One of the things that I find we do is talk about end of life care. I do think is a problem. Saying we do end of life care, or we do care at the end of life, right? I think that's really a problem. I think our brand is providing the best care possible. As you know, I love that phrase because it comes from the vernacular. I didn't make it up. I just listened, and it's there. All people want the best care possible. We deliver the best care possible, not just at the end of life. We deliver the best care possible through the end of life. And if you move from at to through, the whole world changes. If I come to you and you're a patient with advanced heart failure or cancer, and you're worried about palliative care, if I say, well, we give the best care possible at the end of life, good chance you're going to say, well, nice to know, nice to meet you, I'll call you when we get there. Mm-hmm. But we're not there yet now. If I come to you and say, we give the very best care possible through the end of life, well, man, nice to meet you. You could start today, right? It's a big difference.
It's huge.
And I think that is an approach and language that does not deny our mortality, does not deny that the illnesses that we address, the people we serve, are seriously ill and are mortal and may die during our care, will definitely die at some point. But it positions us in service of their lives. I'm afraid that the model that CAPC now is promoting sees us in service in a more transactional way. In service, we're another member of the treatment team that are treating this person's illness, but in that personal realm where somebody is faced with mortality, we are, at least in our public facing aspects, not going to go there. There's going to be left to wonder, well, what do we do if you have the thought? What do we do when we're facing the end of life?
And as you said, if you describe it as care through the end of life, you're creating a time frame. It's like a container for everything that the future might hold. We can and will address whenever it's necessary, and you're making it a huge container, and the end of life part is way off in the future somewhere, so we're not looking at that right now, but we're able to if we need to.
Continuum, right?
Yeah, it's the continuum.
That's what we want to do. We want to create a continuum. We want to create a team of teams for the patient and family. And we're part of that team of teams that goes through the end of life. And we have a continuum with our colleagues in hospice. We share a discipline. We share a specialty there, right? And we're going to, at some point, involve hospice when you're at home, and we're going to work closely with them through the end of your life. We may not be there yet, but just know that we've got you covered, right?
And to make people aware of the continuum, that is actually a huge step forward, so that patients with serious illness are thinking of the fact that they are on a continuum. We all are. We're all on some sort of a continuum. And for them to think in those bigger terms, that is progress, at least, over just being afraid of ever imagining that one day they'll die.
Right. So I, as somebody who, has tried to contribute leadership to the evolution of hospice and palliative care, it just seems strange to me that we're at a time here in the year 2022 when a number of my colleagues are kind of embarrassed about our name. We don't want to say our name. And that can't be good. And, if our name is associated with a lack of hope, or with people, dying, or associated with, let's change the meaning. I have to, a quick anecdote. I was, I spent a decade at Dartmouth, leading the palliative care program at the Dartmouth Hitchcock Medical Center and for the Dartmouth Hitchcock Health System. And there was a time about 3 years after I got there, I came in basically in early 2004, and about 2006 or 2007, early one morning, it was about 6:30 in the morning or 6:15, and I was descending steps, this internal staircase down to the radiation oncology suite, where in a conference room there, the GI tumor board was held every Tuesday morning. And I happened to be walking down with a colleague, an medical oncology colleague of mine who had become a friend by then. And we're coming down the steps, and he stops, and he was in front of me, and he stops and looks back and says, this is remarkable. I said, what? He said, well, you came, has it even been 3 years? And when you came, and they made a big to-do about expanding the palliative care program, and I thought to myself, in all honesty, Ira, The last thing we need is another specialty team touching our patients. They've got enough going on, and my goodness. And I rolled my eyes. But I got to tell you, at this point, I don't know how we used to take care of these people without you guys. And then he went another few steps, and he turned back and said, "But I gotta talk to you. I mean, you gotta change the name, because the phrase, the term palliative care scares the daylights out of people." And I laughed and I said, "Oh man, Mark, I gotta tell you, first, thank you very much. I want to get this on tape. Your first statement, because that's just music to my ears. That's exactly what we've hoped to do. Thank you." About the name, I got to tell you, it's odd that we're having this conversation in the cancer center, because you know what word scares the daylights out of people? I mean, you guys got to start talking about this place as the slightly unusual cell center, right? Because cancer scares the shit out of people. And he laughed, and we moved along and went to GI tumor board. And I just got to say, if we got to change the meaning, which is what we went on to do at Dartmouth. We had to change the meaning of the term palliative care within that health system. It didn't mean you were dying. It meant, and still means today, that you have a serious illness with needs that deserve the very best care we can possibly give you. And that involves this team adding to our team to care for you and your family. And I used to get challenged, like at GI tumor board, so we've got this guy, he's 63 years old, and he's got this, cancer of the head of the pancreas, and we're going to try to downstage him with chemotherapy, and hopefully we can get him to Whipple, right? You going to see this patient, Ira? Absolutely. We want to see this patient. Or the being in the ICU saying, well, the guy, has severe pneumonia on top of his idiopathic pulmonary fibrosis, but he's not about to accept dying, and we think he's got a small but viable possible chance. And do you want to see him and his family? Absolutely, we want to see him and his family. They need all the help they can get, and we're going to help them pull through this, right? And the CHF patients in clinic, right? The cystic fibrosis patients, the end-stage liver disease patients who may or may not get to transplant. All of those people deserve palliative care. And as you build that so that we weren't an alternative to curative or life-prolonging treatment, but an adjunct, a complement with them through the end of life, changed the meaning of the term palliative care. It lost its sting. Mm-hmm. I just suggest that as a field, we should look at that alternative.
I like that. Not necessarily get rid of the word palliative. I mean, what's really behind that is, let's just not talk about anything related to the end of life. It's not just get rid of that word, but doctors don't want to talk about it either. Doctors are just as afraid of the word as patients are.
We've become embarrassed by our own discipline. This is not a good thing. This is not a healthy thing, right? I said to my friend, the oncologist, that day, I said, we could call this program the Rainbow Program, right? We want to refer you to Rainbow Care. But if all we accepted were people who were dying or were soon to be dying, within 2 years, you'd come to me and say, I really would love you to see this patient, but please don't mention rainbows in the room, right? Because it would be associated with giving up, right? With pushing death in their face. I agree with my colleagues about that, right? No, death remains a hard sell. But we want to integrate what we do within the concept of full and healthy living, which, does include living fully as mortal beings.
Exactly. And it includes more than focusing just on the physical body. and treatment of what's happening with the physical body, which is why the palliative care and hospice teams are so valuable, because of that multidisciplinary team approach that can look at all aspects of wholeness and wellness for the patient.
I would even say interdisciplinary team approach. And that gets back to our previous comment, because I think the difference, when I'm asked to distinguish the difference between multidisciplinary and interdisciplinary, I think the difference is that in multidisciplinary, there's multiple disciplines involved in the patient care and contributing ideas and services. Interdisciplinary means that at some point in time, they're actually in the same room, even if it's just a Zoom room, because that's when the synergy happens. That's what the magic.
Excellent point. Excellent point. You're so right about that. And it's the interconnection and the communication that happens between those teams, because a lot of patients now do get multidisciplinary care, but it's completely fragmented and there's no communication or connection between any of the providers.
It's right. It's a collection of transactional interactions. It's just different.
Yeah, and that word transactional keeps coming up in all of these situations. In a way, I feel like that is a problem in our entire society for other institutions as well. We've become very transactional about everything that we do, and we lose a lot. We lose a lot by moving in that direction.
We do. And, I know counterpoints to that. Veterinarians tend to be more relational than medical doctors in so many regards, and maybe except for concierge medicine and the stuff that we used to do, or and it's not like it's all over. There are certainly incredibly good hospice programs and palliative care programs that are more comprehensive and reflect the sort of very much whole person caring model that I the flame of which I try to keep alive. But veterinarians tend to do it better than we do. I actually have as I live in Missoula, Montana most of the time, and you get your tires changed a few times a year around here because of snow, and I have this tire company in town that I have a relationship with. They actually know my name. I walk in and they know. They ask, which of the cars, are you doing the Honda or the Rogue this time, Ira? They call me. It's remarkable. What's up with that? There are. It's just a small business, actually a franchise, but it's owned by a family and small team locally. And there are others, of course. There are places we shop and restaurants where we're known by our names. It's different. I don't know why we can't do that in healthcare.
Exactly. And well, we're at a place where I think our healthcare system is in a lot of trouble right now, and some things seem to be falling apart, and we're going to have to find a way to change. We're pushed there.
Yes. So I know we're getting late in the hour, but I wish I had tangible next steps, and here's what we all need to do. I really do like to assert some cultural and systemic leadership in the work that I do. At the best I can say at the moment is we need to be honest with one another and not assume that just because something's coming from the mouths of hospice and palliative care leaders or is coming from a hospice or a palliative care program that we already agree with it and it's already involves, it's the best there is, because that's, from my perspective, not the case anymore. With regard to some of the deficiencies in our systems, our own palliative care programs, which are also not well staffed in many, if not most places. With the hospice programs, we certainly covered that in this conversation. I think first and foremost, I would ask people not to lose your outrage Some things are just wrong. And if a hospice patient has barriers to seeing their physician, or there's not a good crisis plan, or the nurse that's seeing your mom or your spouse has, you're one of 14 or 15 patients that nurse is caring for, that's wrong. And let's just be honest about that. And then I think we all have to be strong advocates for ourselves and for each other. And, we need to use our shrinking, but our ability to make choices among hospice and palliative care programs, which are these days often determined by your payer or your health system. But we need to complain loudly at times when our loved ones or we ourselves aren't getting the care that we need. We need to fire and choose other programs when necessary. We need to ask, think about who owns this program. And I would just, I would assert that in general, as a generality, community-based nonprofit programs tend to provide better care. Not always, and they're not perfect. I'm not trying to in any way assert that, but be an advocate and think about one of the criteria, and one of the questions to ask is, who owns it?
That's a good point. And I would say if you happen to be fortunate enough to have a community-based nonprofit hospice and or palliative care organization in your community, help support them. Like, please go to fundraisers, like ask what they need, be a volunteer, step up, because it is fortunate if you have an organization like that available to you, and don't take it for granted.
I so strongly agree. Put them on your annual giving list. The local nonprofit hospice program deserves your support. If you've got time on your hands, think about supporting them in other ways, volunteering, either in office work or seeing patients if that draws you, or supporting them. Pet therapy. My dear sister Molly has long been a pet volunteer. I mean, not her herself, but her dogs, to visit patients. Spread some joy.
Exactly. So let's take what's working well, or wherever we find something that's good in our field, let's amplify that, and let's see if we can't get creative. And so this is our little way of creating some synergy between us, and maybe, who knows, maybe we'll have some ideas down the road, and maybe we'll sleep better after talking about it.
Well, this has been very therapeutic for me, Dr. Wyatt. Thank you for listening to me. And I feel like my anxiety closet has just the airing of it has helped me a lot.
Well, I could have charged you for it if I had known it was going to be so helpful, but
I'll get the martinis next time.
All right, that sounds good. Well, thank you for joining me, and it's been a great conversation, and it does feel good. It feels good that we air these issues and be able to just talk about it freely and openly.
I agree. That's where solutions start, by being honest, being connected over these issues, expressing oneself, feeling heard and understood. I feel heard and understood. Thank you for that.
You're welcome. Well, I hope we empower other people to speak up when they see injustices and when they see things that are wrong in their community or their field. So thanks, Ira.
I look forward to talking with you again. I'm committed to staying, at the forefront of this podcast.
All right, I'll keep you informed when you're slipping from the rankings, and we'll get you back here again.
All right.
All right.
Take care.
You too. Bye. Well, I hope you enjoyed my conversation with Dr. Ira Byock. I always enjoyed having discussions with Ira. He is full of so much knowledge and experience and also so much wisdom. And having this vantage point of being able to look back on the progression and the evolution of hospice and palliative care over the long haul is really helpful. And I spoke about that with Barbara Carnes as well when I interviewed her, another person who has been a pioneer in this movement, and having this opportunity to watch all of the various iterations of end-of-life care that we have been through so far. And yes, we are at a place right now that is very concerning. It feels as if we're watching hospice care be consumed before our very eyes and being absorbed into a medical system, so that end-of-life care is not only being medicalized, it's being monetized. And that is a frightening thing to see. However, I'm not ever one to become pessimistic or to lose my hope and my positivity about things, because I see times like this when it feels like things are falling apart as great opportunities for change to happen. And remember, hospice itself was born from a time when there was a lot of despair and unhappiness about the way people were being cared for at the end of life. And whatever discomfort and unhappiness we feel right now about what's happening to our beloved world of hospice, we can utilize that as fuel to help us create the next new out-of-the-box thing that's going to happen to make sure that people get the care they need at the end of life. So this is a time when we need to stay hopeful and passionate. Like Ira said, not lose our outrage, speak out about what's wrong and what's happening, but also stay creative and collaborative. And we need to all come together with our ideas and our thoughts. I've been very attracted to the social model hospice for a number of years now and love that sort of out of the box model. I know it has struggled to get off the ground in many communities, but there's something within that model that I feel like has some potential and some hope here. I have also met some small hospices that have not become Medicare certified, have remained just nonprofits doing their work and not accepting Medicare dollars. And I know that used to be controversial and used to be seen as a negative thing, but there's a room now for something new and different to take place. And it's time for all of us to get creative. I think the end-of-life doula movement also has hope here. I think there is promise within that movement for how we're going to move forward and create something new that is going to make sure we provide better and better care for people at the end of life and not see that care become medicalized and monetized by this behemoth medical system that is threatening us right now. So I have hope, but we have to begin by looking at the problems honestly. So that was the reason for this conversation, to really take apart and be transparent about what is happening so we understand the scope of the problems that are out there that we're dealing with. And yes, right now there may not be obvious solutions, but I think Ira is right. Let's keep spreading joy wherever we can. Let's do our own work the best way we can, but let's not be afraid to speak up. Let's not be afraid to point out what's wrong when we see it being wrong. Let's not get romantic or idealistic about hospice care, which we love. And I fall in that camp of someone, I constantly idealize hospice care, but let's be brutally honest here about how things are changing and what's happening so that we can confront it and really look at it. So thank you for listening to this conversation. And, I would love to be part of starting something new, even a think tank about how do we how do we respond to what's happening in our own field right now? And how could we create something new from the ashes of what is being destroyed before our eyes? So contact me if you have ideas or thoughts, and let's use this platform as a place where we might start to gather ideas and inspiration for the future. So email me at kwyattmd.com kwyattmd@comcast.net if you have any ideas that you'd like to share, and let's see what we could create together. I would love to work on that with those of you. I know there are plenty of people out there who are also passionate and inspired. So I will also ask you, if you enjoy content like this, please share it far and wide. If you know someone else who might like to listen in and hear this conversation we just had, please let them know about it. Share the episode. You can also show people how to subscribe to the podcast or follow it, depending on what platform they're listening on. And if you're a regular listener, be sure that you have subscribed as well, and then also leave a rating and a review for the podcast. I hate to ask for that. Those things are annoying to me in some ways, but the reality is the way algorithms work on these platforms, especially Apple Podcasts, it takes a certain number of positive reviews for a podcast to rise high enough in the rankings that it actually gets shown to people when they're searching for this kind of information. So that's why I have to ask for that. Also, your support in any way is appreciated. If you go to my page at eoluniversity.com/support, I appreciate the contributions people have made in the past. And again, as I have suggested before, for this month, I would also appreciate any of you purchasing my dear friend's book, All the Flowers of the Mountain. The ebook is just $9.99. It's available for pre-order right now. This is like a project, it's kind of an end-of-life project of meaning making, and I've been honored to be part of it. It's been a labor of love. And so it's available to pre-order right now, and that would be a beautiful way to offer your support to me and this podcast and to my dear friend. So there will be a link for that in the show notes at eolupodcast.com. So thanks again for listening. Tune in next week for another fascinating interview. I'll be back then. And until then, remember that we're here for love. So face your fear. We all have lots of fear about the future right now. We just need to face it and look at it directly. Be ready for whatever happens. Could be anything. And love each and every moment of your beautiful life. Bye-bye.